Rapid Fire CCS Cases Review, Endocrine and Renal. In this video, we will rapidly review the endocrine and renal CCS cases such that once you master these cases, you will be able to score more than 90% on each of the endocrine and renal cases. If you like this content, please like, share, subscribe, and follow for more. Let's begin. Diabetic ketoacidosis. So you already know that diabetic ketoacidosis is a problem of hyperglycemia along with electrolyte abnormality. So therefore, in the diagnosis, we have to monitor both the blood glucose and electrolytes too early. Now in the treatment, I have made a mnemonic so that we don't forget it, because diabetic ketoacidosis again is one very serious condition, and at the same time it's a very common condition to be encountered, right, and very important condition. Therefore, you cannot miss any of these steps. Therefore, I made a mnemonic of bike. So bike, there are two I square, and then D, and then bike. So I square first of all stands for IV fluids and insulin. Since this is a hyperglycemic state, we want to dilute the blood and bring down the glucose levels. Next, once the glucose levels are down below 200, between 200 to 250, then we can also add dextrose. So we don't want the patient to even go into hypoglycemia, which too much insulin. Therefore, we are going to begin with IV fluids, insulin with I, and then for D, we will add the dextrose when the glucose is between 200 to 250. Next is B and K, bi and chi. So B is basically for bicarb if the pH is below 6.9. So we are not going to give it in all the patients, but if on ABGs and electrolytes you find that the pH is less than 6.9, then give bicarb. Similarly, if the potassium is below 5.3, then you are going to give potassium supplementation, of course. And you already know that the insulin levels, once you give insulin also tends to move the potassium from the serum into the cells. Therefore, if at any point by this electrolyte monitoring you find out that pH is less than 6.9, immediately give bicarb. If the potassium is less than 5.3, immediately give potassium. Okay. Next off, we have Cushing's syndrome. So for the diagnosis of Cushing's syndrome, whenever you're going to think in two ways. One would be the blood test and one would be the radiological. And blood tests are basically the confirmatory tests, which will give you an idea that yes, this is Cushing's syndrome. So beginning from the head, first of all, you can do an ACTH levels. And in primary Cushing's syndrome, which involves the central or the brain adenoma, the ACTH levels would be increased. Whereas in secondary Cushing's syndrome, which is basically due to some adrenal tumor, then ACTH would be suppressed, right? So it can either be very increased or decreased. Similarly, on dexamethasone suppression test, if you find increased cortisol, that is also Cushing's disease. And then in cortisol, we can also do cortisol 24 hours in the urine. So that would be basically blood and urine test, right? So two blood tests and one urine test. Next off, we have the radiological test that we can do, again depending upon whether it is a thing that's happening in the brain or a thing that's happening in the adrenal glands. We can do a CT of the head if we are suspecting Cushing's disease, and if we are suspecting adenoma, we are going to do an adrenal scan. And the treatment is also, of course, going to depend upon the cause, that whether we are going to do remove an adrenal tumor, or we are going to remove a brain tumor. Next off, we have Zollinger-Ellison syndrome, which is also known as a gastrinoma, which is basically a tumor of the duodenum or the pancreas, which produces too much acid. And because of the too much acid production, it results in chronic diarrhea and heartburn. So what are you going to do in the diagnosis? So one thing that I just told you, that the serum levels of gastrin are going to be increased. So this will be a one test which is going to confirm your diagnosis that yes, this patient has increased serum gastrin. Then we can localize the tumor and do a histopathological diagnosis along with a radiological diagnosis, right? So remember that I said that whenever we have any sort of tumor or cancer, so our goal is that we can do some sort of blood test, then some sort of histopathological diagnosis, and some sort of radiological diagnosis. So this absolutely fits over here, that gastrin per se is not a tumor marker, but it is raised in the blood in cases of gastrinoma. So in the blood, you're going to do serum gastrin. For the histopathological diagnosis, you can do an endoscopy, and if the tumor is in the duodenum, you can do an histopathological diagnosis. And then for the radiology, you can do CT abdomen in order to look for mets, right? Next off, you have the treatment. Of course, one can be the symptomatic and one will be the definitive. So symptomatic is that you need to control the extra acid that is being produced. So that you can do by administering a PPI, pantoprazole. Next off is the definitive treatment, which is the removal of the tumor. You're going to consult surgery and do the pre-surgical orders of NICE PT, NPO, informed consent, C for cefazolin, E for EKG, P for PT, APTT, and then T for blood transfusion and cross match. And a very important thing is the prevention, that once you have found that this patient has some sort of a pancreatic tumor and this pancreatic tumor was a gastrinoma, so it's possible that this pancreatic tumor was a part of the MEN1 syndrome. That's why it's very important to screen for the other two things that are present in MEN1. So how do you remember MEN1? You can remember one by means of 3 P's, going from the head to the neck and then to the abdomen. So in the head there is pituitary adenoma, which you can screen with prolactin levels, because the most common secretion of the pituitary adenoma is actually prolactin. So you can screen with prolactin. Next off, we have parathyroid hyperplasia, and of course, as the name says, that it's going to overproduce parathyroid. So you can do parathyroid as well as serum calcium levels. And next off, we have pancreatic tumor, which is of course Zollinger-Ellison syndrome and gastrinoma. So in case that you have any parathyroid hyperplasia or pituitary adenoma, then don't forget to screen for the pancreatic tumor. And of course, like you can screen for the pancreatic tumor by, of course, the signs and symptoms, and besides that, if the patient will also have like increased serum gastrin levels. Okay, then we have MEN2A and MEN2B. So let's quickly discuss them over here as well, since we are discussing about MEN1. So we know that what we are going to screen for in case a person has a pheochromocytoma or is diagnosed with medullary carcinoma of the thyroid, then you must know that we need to screen for both MEN2A and MEN2B. So diagnosis of MEN2B will be straightforward. Of course, like the patient would have mucosal neuromas and marfanoid body habitus. So if a patient presents with these two, then be sure that you have to screen him for medullary carcinoma of the thyroid with calcitonin levels and pheochromocytoma with plasma-free metanephrine's level. And on the other hand, again, as I was saying, that the patient has hyperparathyroidism and has increased parathyroid levels causing increased calcium levels, then again screen him for medullary carcinoma of the thyroid with calcitonin and pheochromocytoma with plasma-free metanephrine's, and vice versa. If the patient has pheochromocytoma, then screen him for medullary carcinoma with calcitonin as well as parathyroid hyperplasia with parathyroid hormone and calcium levels. Next off, we have hypothyroidism. So for hypothyroidism, again, this is also a very important thing, and we do not need to like forget any of these tests because it affects so much or so many organ systems. Therefore, I have made a mnemonic for it, just like we made one for diabetic ketoacidosis, so one for hypothyroidism as well, and that would be LFT high definition, right? So we are going to get some LFTs, liver function tests, which are high definition. So what does LFT stand for? One is lipid profile, because hypothyroidism can cause lipid abnormalities. Next off is free T4 and TSH. Of course, the two basic tests of thyroid, free T4 and TSH, will stand for F for free T4, T for TSH. Next off, we have HD. HD is hemoglobin A1C. Of course, thyroid abnormalities can also cause blood glucose abnormalities, and D is for depression index, because hypothyroidism might also be associated with depression. And of course, the treatment is replace the thyroid hormone, which is levothyroxine. Next off, for hyperthyroidism, the battery of diagnostic tests is also going to be similar. So it will be LFT, HD, so L for lipid profile, F for free T4, T for TSH, H for hemoglobin A1C, and D for depression index. But the treatment would be slightly different, and the goals of treatment would also be slightly different. One would be the symptomatic management. So we want to control the extraadrenergic effects that are taking place and causing the patient's palpitations and tremors and restlessness, right? So because of the extra epinephrine or norepinephrine. So we are going to do this by using a beta blocker, which will block the sympathetic outflow. And next off, we have to, of course, destroy the extra thyroid hormone that is being secreted. So in order to destroy those parts of the thyroid, we can use either pethimazole or PT, propylthiouracil. And of course, it's an endocrinology case, so we will consult the endocrinologist. Now we are going to begin the renal CCS cases. So suppose you have a patient and he has either nephritic or nephrotic syndrome. So generally in kids, it's like nephrotic syndrome, but there can also be like nephritic syndrome. But one very important thing is that we are not going to admit the patient to the inpatient unit, rather he can be managed outpatient, right? So for this as well, for nephritic and nephrotic syndrome, again, they are very important, and I have divided them into two main types of diagnosis, right? So first diagnosis would be we are going to do something in the serum, and second is that we are going to do something radiologically. So radiologically is, of course, like is very easy. Do something for the chest and do something for the abdomen. The chest, most basic test for the chest can be chest x-ray, and the most basic test from the abdomen can be ultrasound of the abdomen, right? So anything that's wrong with the abdomen or anything that's wrong with the chest, for example in vasculitides, it can be ruled out with chest x-ray, ultrasound, abdomen. Now for the serum, we have all these specific causes, that which are the causes that can basically cause nephritic or nephrotic syndrome. We are going to rule them out one by one, and I have again made a mnemonic for them so that we can remember them on our fingertips, because there are so many different causes and it's possible that we might forget any one of them. So my mnemonic for them is American College of Gynecologists, right? I don't know if there is only American College of only gynecologists, but okay, I have named it such. So A3, C2 and G1. So right, so we're going to go 3, 2, 1, A, C, G, right? So for A, what are the most important causes of nephritic syndrome if you are to think? So first of all, it would be PSGN, post streptococcal glomerulonephritis. For it, we can do with the A, ASO titters, right? Next off, we have glomerulonephritis, which are caused by some sort of ANCA-associated vasculitis, right? Which include the vaginal granulomatosis or the Churg straws or the microscopic polyangiitis. So they are all ANCA associated. So next we are going to, after ASO titters, we are going to do ANCA. And next off, we have the most important cause like lupus nephritis. We can do an ANA or anti-DSTNA. So these are the three A's: ASO, ANCA, along with ANA or anti-DSTNA. Next, we are going to do two C's, which will be complement level C3, which will be decreased in PSGN and will be normal in minimal change disease nephrotic syndrome, and cryoglobulin levels, right? And then we are left with G. Of course, G is one very specific cause, which is Goodpasture syndrome, having anti-GBM antibodies. So it's just a quick review for nephritic and nephrotic syndrome. Let's get the easy thing out. That is the radiological test of basic chest, which is chest x-ray, and the basic abdomen, which is ultrasound abdomen. Next, let's rule out specific causes with A, C, G, right? And in A3, C2, and G1. A3 includes ASO titters, ANCA, along with an ANA or anti-DSTNA. C2 includes complement levels C3 and possibly C4 and cryoglobulin levels, and G is anti-GBM antibodies. Now, for the treatment, of course, it's going to depend upon the exact specific cause, whether it's lupus nephritis or any other thing, but the general supportive treatment is going to remain the same, that if the patient has edema or fluid overload, we will give furosemide to improve his renal function and of course to diurese him of the extra fluid. And of course, along with giving furosemide, we always do input output monitoring, and we can insert a Foley's catheter as well for the monitoring. Of course, we're going to do a nephrology consult, and if the patient has nephritic syndrome with hypertension, we can give him a calcium channel blocker such as nifedipine. And the prevention, again, if the patient is developing some sort of edema, then we are going to advise him a low salt diet along with fluid restriction and nutritionist consultation. Next off, we have UTI. Again, for the diagnosis of UTI, you need to consider the specific tests, right? And then you need to rule out some other conditions, right? Rule out some complicated conditions or some simple conditions. So the most specific test, of course, would be the urine gram stain as well as urine analysis, and then the culture sensitivity, specifically in those who are pregnant and kids, because they are dangerous in pregnant women, and for the kids, of course, there might be some underlying other cause. So therefore, we definitely want to do urine culture sensitivity in pregnant and those who are kids, right? Next off, we are going to rule something out, that if the patient is repeatedly having UTIs, it's possible that he has chlamydia or gonorrhea infection, which we will rule out with the NAT test, nucleic acid amplification test. And then if the patient is having recurrent UTIs, then in this situation, we will of course do the urine analysis and the urine culture sensitivity along with the NAT test for gonorrhea and chlamydia. But specifically, we can do a renal ultrasound, CT of the abdomen, and voiding cystography, in which of course we are going to see whether the patient has posterior urethral valves or some sort of refluxes, vesicoureteric reflux is taking place, right? So this is the order, that first the simplest renal ultrasound, and then we are going to move to the VCUG as well as the CT of the abdomen. And the treatment for simple UTIs will be nitrofurantoin or phosphomycin, and if the patient is non-pregnant, we can also give trimethoprim sulfamethoxazole or ciprofloxacin. Next off, we have prostatitis. So again, the prostatitis is similarly an infection of the prostate, just like UTI. So urine gram stain, basic urine analysis, basic urine culture sensitivity, along with gonorrhea and chlamydia urine antigen or nucleic acid amplification test. But the treatment is slightly different. If it's gonorrhea and chlamydia, of course, you are going to treat the underlying cause with like if it is chlamydia, you're going to give him azithromycin, or gonorrhea with ceftriaxone, or chlamydia can be azithromycin, or if the patient is not pregnant, we can also use doxycycline, right? But if that is not the case, and the patient has actually, like, he's an elderly individual greater than 30 and he has E. coli, then in that situation we are specifically going to treat the infection with ciprofloxacin. Next off, we have end stage renal disease. Of course, like, one is the basic metabolic profile in which you are going to see urea and creatinine ratio. That is a given. But beyond that, we are going to do a radiological test of ultrasound abdomen for the kidneys so that we can visualize that the kidneys are atrophic or of normal size. Then the treatment, one is the supportive treatment for the time being, just symptomatic relief, which would be the hemodialysis. And if the patient develops hyperkalemia, then we are going to give him calcium gluconate so that we can stabilize the heart membranes and prevent the development of arrhythmias. And of course, consult nephrology along with the definitive treatment of kidney transplant. Next off, we have hypercalcemia. So you know that the most important cause of hypercalcemia, it can be due to malignancy, but the most important cause would be hyperparathyroidism. So you can look for the malignancy, where exactly the malignancy is taking place, or it's multiple myeloma with a blood smear, or you can do the parathyroid levels, and that would be increased if it is due to hyperparathyroidism. So the most important thing is, how are you going to manage this increased calcium levels? So one is going to be the symptomatic relief, that we want to dilute the blood levels of calcium so that the hypercalcemia does not have its adverse effects. So we can do that with fluids. Next off, we want to decrease the levels of parathyroid if it is really due to hyperparathyroidism, and of course if it is due to some other cause like hypercalcemia of malignancy or some other cause of hypercalcemia, then we just want to bring down the calcium levels, right? So symptomatic relief with the fluids. After that, decrease parathyroid hormone levels with calcitonin. Calcitonin is basically, it alters the calcium sensing ability of parathyroid hormone, parathyroid gland, and it senses that there is too much calcium, so the parathyroid hormone levels basically go down, and in turn calcium levels go down. And bisphosphonate is basically like zoledronic acid, they decrease the osteoclast bone resorption, so decrease the calcium levels. So for hypercalcemia, just to parathyroid hormone levels, whereas for the treatment, give fluids along with calcitonin along with bisphosphonates. Next off, you have hyperkalemia. So hyperkalemia can basically present as weakness similar to GBS, and of course we will do the basic test of Cube T3 MPL. Cube T3 was CBC, then CRP, then complete metabolic profile, chest X-ray along with creatine phosphokinase, U for urine analysis, urine culture sensitivity, urine toxicology, B for beta HCG along with HbA1c, E for EKG, echo as ESR, T for troponin, TSH along with toxicology screen, M for magnesium, P for phosphate, P for PTA, PTT, and then L for lipid, LDH, and lactate, right? And the treatment for hyperkalemia, again, we want to stabilize the heart cell membrane so the patient does not develop life-threatening anemias with calcium gluconate, and then we want to bring down the potassium level. So as we were discussing previously in diabetic ketoacidosis, then insulin and dextrose, insulin is one thing that is going to push the potassium from the blood into the cells, right? And as it pushes the potassium from the serum into the cells, it's also going to push glucose inside the cells. So the patient can also have hypoglycemia. So just remember, whenever you give insulin, do remember to give dextrose as well. And you can also use palitromer, which is basically a potassium binding agent, and it will bring down the potassium levels. And one important thing is that you're going to avoid hemodialysis until the hyperkalemia is refractory to the conservative management, and of course in the prevention would be a low potassium diet. Next off, we have nephrolithiasis. So basically we have kidney stones. So we can basically generally do ultrasound KUB or X-ray KUB, but they are not very specific. The gold standard for the diagnosis of nephrolithiasis would be CT abdomen and pelvis. And besides that, that's one radiological test which will help us confirm the diagnosis, right? And besides that, there's some sort of like a screening test or one test to rule out other things. So one test for screening, that is, we are going to look at the presence of crystals in the urine. That can be done with the urine strain. And then for ruling out pancreatitis, since this can mimic pancreatitis, it's a back pain, and pancreatitis, the pain of pancreatitis is also going towards the back, so we can do amylase and lipase levels as well. And then in the treatment, of course, the patient is in severe pain, pain, therefore the first thing is to relieve the pain and with morphine. And then we are going to give IV fluids because the patient might be dehydrated, unable to intake anything, and might be vomiting as well, so you can give ondansetron and make him NPO. And then the specific or definitive treatment is to help pass the stones with tamsulosin or nifedipine, and then you're also going to do a urology consult. And this concludes our rapid review for renal as well as endocrine. If you like this video, please like, share, subscribe, along with follow for more videos, and I'll see you in the next video. Happy studying.